Right. So the approach that Malcolm and I have been taking in Plymouth is based on a single sided approach from the right side with VATS thoracoscopically, threading this bracelet, if you like, around the posterior wall and the pulmonary veins. There's a device which delivers bipolar energy if it can suck the muscle up into the groove. We're not sure how much that actually occurs. And then there is unipolar energy delivered from the adhered device. So that's at the first stage, and then 2-3 months later, they all come into the cardiac catheter lab, where we study them in much the way I was talking about, and we aim to look to confirm isolation of the posterior wall and then add a right atrial isthmus line. We got into this because of the data from Italy, which seemed to show extremely good results on follow-up, which were said to be on ILR from Minaretto's group. And these are just point out the workup. We do a CT scan on all of them to look for coronaries before we set off. We tell all the patients that it's going to be a 2-stage procedure, and we ask them, will they have a sternotomy if they've got adhesions? And we're very careful about our process of anticoagulation management, particularly after we had a stroke in the early phase. So we've kept this very simple, and the plan is to do 50 cases with just this simple approach going around the posterior wall and pulmonary veins, and we will then take stock of this 2-stage approach. I'm going to skip through the process by which we do the catheter ablation analysis and closure of these lines. Basically, on the ones that haven't got complete isolation, we'll look for where the gaps are in the surgical lines, which we can identify through the mapping technique, and burn to close the gaps, and then convince ourselves that we have got complete isolation. Here's an example of where isolation of the second stage is achieved. And this is the sort of picture we'll see with an area that's completely inert on the back wall once there's isolation has taken place. So these are the results. 41 patients done to date, all persistent atrial fibrillation. They've had a median of 22.5 months of continuous atrial fibrillation leading right up to the time of surgery. Moderate dilatation of the left atrium, around about 65. I heard the comment, which was a very sensible one, about trying to avoid enormously obese people in your early phase, but I'm afraid the Devon cream teas have largely defeated us, and we have some pretty large patients going on table for Malcolm to deal with. And I think just importantly, we have to look at the complications that have come about. 2 that we couldn't do because when Malcolm got in there was a lot of adhesions present that wouldn't allow passage of the device. We had one patient who was absolutely fine the evening after his procedure. It had all gone fine, and the next day he had a massive stroke and subsequently died from that. We've also noticed that if we look at the chest x-rays before and after, we see significant right hemidiaphragm elevation, suggesting a transient nerve palsy from the phrenic nerve in 10 of the 41. However, when they get to the second stage, all but 3 had completely recovered. We fluoro them when we put them on table to make sure there is normal diaphragmatic motion, and the remaining 3 showed that there was movement, but that it was reduced, but it was in the right direction. So this must be a nerve praxis rather than a severing of the nerve. But it's interesting whether this is due to pulling on the stay sutures. 1 TIA, 1 hemothorax in a man who jumped on a flight about 4 days after his procedure against advice and flew to Germany. But he survived, fortunately, that process. So 38 patients in follow-up. And the thing that I think we are really trying to address at the moment is that from the 27 cases that have gone on to the second stage study, the bulk of them are still in atrial fibrillation or atrial tachycardia at the time they come to the follow-up study, and only 7 of those cases have had isolation of the posterior wall. In the remaining 20, there have been gaps which have had to be closed at the catheter ablation part of the procedure, and in one of those I failed to close the gap because it was lying straight over the esophagus, and before we got isolation, I lost my nerve and decided not to give any more energy over the esophagus. And we do the CTI ablation in all of them, which was successful in all of them. So if we look out to 1 year, 7 out of 10 patients are now greater than 1 year, and 10 patients are greater than 1 year, and 7 of those are in sinus rhythm. 70% of them off antiarrhythmic drugs, but there's 1 on flecainide, 1 on sotal, 1 on amiodarone. There's 1 in atypical flutter and 2 in PAF. The atypical flutter guy has a pacemaker in situ. He says he's completely fine, asymptomatic, doesn't want anything done. That pacemaker was there prior to the original procedure. 1 of the PAF patients is properly symptomatic. He's awaiting redo at the moment. And if we look at the headline figures, if you take there's 1 patient on amiodarone who has been completely free of AF since the blanking period. If you include him at 66% free of AF, if you exclude him, 62%. And if we look at the cohort that are coming up towards the 1 year mark, we are seeing a reasonably good number that are in fairly continuous atrial fibrillation. So, So in summary, we're trying to focus on long-standing persistent AF, as I said. We're doing a 2-stage procedure on all the patients, and we will reevaluate things at the 50 cases mark. And really the proof of concept, as I think I was trying to bang out in my talk about catheter ablation, is when we see what's actually happened out to 5 years. Thank you.